So, good evening, everybody. I think this will be our last session for this year. And on popular demand, we have Dr. Sundar back here with us. So, over to you, Hansika, to take this forward.
Uh, Thank you, ma'am. Good evening, everyone. Thank you for joining us this evening. So, today's topic of learning is dystonia and cerebral palsy, physiotherapy approach. And our speaker for today is Dr. R.M. Sundar Kumar. Dr. Sundar has over 19 years of experience in physiotherapy. He treats children with neurological and developmental disabilities. He's also certified in neurodevelopmental treatment and USC trained in sensory integration, and also has an advanced certification in general movement assessments. Currently, Dr. Sundar Kumar is the director of Therakinos, a center for developmental specializing in pediatric physiotherapy in Bangalore. Thank you, sir, today. Without further ado, I would like to welcome Dr. Sundar this evening. Over to you, sir.
Uh, Thanks a lot for Brainchild Trust for giving me an opportunity again to do this uh, in front of an audience who are very enthusiastic. Dystonia is always a pretty challenging topic, and having such a topic in a platform like this is going to be extremely challenging. But I would try to do my level best to get the point across. Okay, so initial briefing is what we are going to see is we are not going to see all kinds of dystonia. We are not going to see about dystonia of a familial origin. We are not going to talk about dystonia which is idiopathic or a dystonia that is metabolic. We are not going to talk about dystonia that is focal dystonias. No, we are not going to talk about all kinds of, because dystonia is a huge topic. But what we are going to do today is we are trying to narrow it down to dystonia and cerebral palsy. Now, that is what we are going to talk about. Why we are going to talk about is because predominant dystonia in childhood is something you would start seeing it in cerebral palsy. So, and many of us as PTs who are working with children, the most commonest dystonia that you would be seeing it in the clinic, or I would be seeing it in the clinic, is dystonia and cerebral palsy. But can I also see dystonias in other childhood disorders? As of course, yes, but we are not going to discuss about all that. But what we would be discussing is we would be restricting our topic today to cerebral palsy. But can I apply those principles in other dystonias? Of course, yes, we can apply these principles, what we are going to discuss today, in other areas, right? So when we talk about dystonia and cerebral palsy, we are classically looking at children who have the functional ability based on gross motor functional classification system 3 to 5. That means these are the children who are very severely involved. Their gross motor system is extremely challenging. They have learned to sit, they have not learned to stand, they have not learned to walk. I hope all the participants who are here would know about the gross motor functional classification system. So the children that we would be talking today is mostly between the gross motor functional classification system 3 to 5. To be very honest, I'm not an expert in dystonia. I don't claim to be an expert in dystonia. Because it's a very challenging area to work with. So what I would be doing today is whatever the pearls that I've learned over the years, that I would be sharing it with you. One of the most important thing when we are talking about dystonia is we do not have much of literature evidence in terms of what we are doing with these children. Do we have evidences for the kind of treatment that we are using it? We have a very limited evidence, or we do not have any evidence for what we are doing. Why does it? Because research is absolutely complex. The variety of dystonia is variable. It is heterogeneous. You don't see dystonia of same pattern in different kinds of children with the same diagnosis. And then normalizing or trying to homogenize treatment solve such a heterogeneous problem is going to be very challenging. So we do not have much of a literature evidence to support what we are doing. What is available? What is the evidence-based available treatment option for dystonia? That is quite limited. That is something which we all have to understand as we start going through this or navigating this presentation, right? Now, some of the experts that I follow in the field of dystonia is, I've listed it here. These are the people that I generally follow when I wanted to look for some ideas. I wanted to see what kind of research work that they have come up with. Now, these are the people I would look at and then see that, you know, what is happening in the field of dystonia and cerebral palsy. I would also encourage you to go and look at their research work, their work in the field, so that, you know, you would learn a lot about handling children with dystonia, right? So with that initial briefing, that, no, we would go and then try to understand what is the definition of dystonia. See, many of us, when we think about dystonia, we always think about the twisting motion, right? Shoulder twisting, and then we would always look about arching of the spine, head into extension. All this is something, no, which we will come into mind as a physiotherapist when we think about dystonia. But one of the most important thing that I would always try to direct people who are working with me, or try to speak about dystonia with my colleagues, I would always say that, now always think about overflow of muscles when a child trying to initiate a voluntary action. That is something which I would always draw people's attention to look at. Now, why do I say that? Is because many of the dystonias are severe, where when it is severe, you would see a lot of twisting motions of the shoulder, you would see a lot of a twisting motion of the wrist, you will see a lot of a twisting motion of the hips and the lower legs when the dystonia is very severe. But many times we also need to remember that dystonia may be mild, where you would not see a twisting motion there when you see a child, but still a dystonia would be present in a very subtle way. Now, how do we really understand whether a child has a dystonia or not? One of the features that I would use in my assessment is basically, I would see whether there is a component, whether there is a movement, an involuntary movement is triggered by an involuntary action. When a child is attempting to do a voluntary action, is there an involuntary movement that is happening in a part that is not intended, and it gets increased whenever a child attempts a voluntary action. So now, say for an example, if a child is reaching for an object with the right hand, is there an involuntary action that is happening in a different part of the body? So that is something which you call it as a dystonia, and then that results as the result of overflow of muscle activation, right? And the most important thing is, whenever we talk about dystonia, is it has to interfere or limit function. That is something which is very important. This is the classical definition that is used all over across the world in trying to define what dystonia is. It's not just twisting motion alone that you would see in children. You would also need to see that whether it is triggered by a voluntary action happening in a part that is not a part of the task or an action the child is doing, and it is as a result of the overflow of muscle activation. So I hope that the definition is clear. I would show a couple of children with videos, that then we would understand this definition better, but we would just move on before I show you those videos. Okay, so how do we understand dystonia and CP? This is again life cannot be associated with cerebral palsy. Dystonia that is you see in the first year of life probably could be metabolic or from a familial cause. So then when do we see dystonia and cerebral palsy? Dystonia as a feature starts appearing as the child grows, when the brain starts evolving, and then you would eventually see it somewhere between 2 to 6 years for a child who has a diagnosis of cerebral palsy, right? Now, how do you classify tone in cerebral palsy? This is a surveillance of cerebral palsy in Europe. They have come up with a beautiful classification of how do you classify children with various tonal abnormalities in cerebral palsy. If you look at it, you have dyskinetic. It comes under a dyskinetic cerebral palsy. Dyskinetics in an umbrella term of dyskinetic cerebral palsy, and which is again further classified into dystonic cerebral palsy and choreoathetotic cerebral palsy. Now, the most important thing that we need to understand is when we are classifying dystonia, the most important questions I would always ask the families, or what I would always look at in my children, is a variable tone. Now, if you start at the top of this tree, you will see that is the tone varying. So a variable tone is a classical feature of child with dystonia. So that's something which we need to understand. So the prevalence of dystonia. So how much of percentage of children with cerebral palsy have dystonia? So this is one of the study done by Wright in 2017. He looked at around 150 children. So what he looked at it is, if you look at, he looked at 150 children. When you classify this, when he was classifying this 150 children, they identified it, only 13% of the children have a predominant motor type as dystonia, only 13%. But when they looked at the dystonic features, even in children who are recognized as spastic cerebral palsy, they identified that even a child with spastic cerebral palsy has some components of dystonia. You look at all this, the Venn diagram here. When you look at this Venn diagram, you would see that there is a lot of overlapping between spasticity and dystonia. So even if a child walks into your clinic with spasticity or a spastic cerebral palsy, there is always a chance that they would have some amount of dystonic features. So that is very important. So if you take that into an account, according to the study, 80 to 85% of the children with cerebral palsy has dystonia, rather than only looking at a predominant motor type has dystonia. If you only look at predominant motor type as a dystonia, the prominent or a predominant motor type as dystonia, it's only 13% of the population had dystonia and cerebral palsy out of those 120 children that they have evaluated. But if you look at all the other tones, if you also include spasticity into it and then start observing them whether they have a dystonia, then you realize that some of these children also do have dystonia, even though they have a predominant tonal pattern as spasticity. So it's very important that we need to be evaluating them, looking at them, even though they have a predominant motor type as spastic cerebral palsy. So that is very important, right? So this is something which is very important for all of us to read, learn, and understand. So I've given you the reference below. These are the top 10 themes that researchers have developed in terms of what we need to do with children with dystonia and cerebral palsy. So I'm not going to go through all these 10. The first 5 which I've highlighted in green font is basically what we would be looking at. Some of these elements of these would be looking at in our presentation, but it is a good, very, very good article for us to go and learn about what is that most important that we as practitioners should understand, learn, and adapt in our practice when we are looking at children with dystonia, right? So that's about the themes. Then coming to the dystonia diagnosis, this is very important. So one of the most important thing that you would try to differentiate dystonia from other types of tonal abnormality is a variable tone. Now, this is something which you can take it from the history. The family would give you that information. The family would always say that, no, sometimes he's very stiff, sometimes he is not that stiff. Sometimes when he's very cranky, he becomes extremely stiff. Sometimes when he is laughing, that he becomes extremely stiff. Sometimes when he's excited or she's excited that no, I see my child is no very stiff. Sometimes when I'm doing this particular posture, when I put him this particular posture, he becomes extremely stiff. Other times he is very relaxed. Now, these are the kinds of information that no family would always give it to you. I don't understand that whether sometimes he looks very stiff, sometimes he does not look very stiff. He is absolutely relaxed. So that is something which you can get it from the parents, right? So that would kind of assist you in making a differentiation between whether it is a dystonia or a spastic cerebral palsy, right? But how do you differentiate with your examination? How do you differentiate a spasticity from dystonia? We always know that spasticity is velocity dependent, right? Dystonia is not velocity dependent. You do a fast passive stretch or a passive movement, and a slow passive movement. With a fast passive movement and a slow passive movement, you will see a difference in the catch. Now that explains spasticity, right? Because spasticity is velocity dependent, but dystonia is not velocity dependent. What happens in dystonia? Dystonia is basically a tone that increases with voluntary effort. When I try to voluntarily move, now what happens is the tone increases. The tone naturally does not increases probably in the moving arm, but it may increase in another part of the body, right? So that is how you kind of differentiate spasticity from dystonia. But if you look at spasticity, that spasticity increases with effort. Generally, no. Spasticity remains constant. The tone remains constant either when you're at rest or when you are initiating a voluntary effort, right? Does the tone vary with emotions? Does the tone vary with emotions? Yes, that's basically what you would be looking at. So if a child comes into my clinic and I'm evaluating this child, I would look at, is the mood and emotions causing a change in tone? That I would observe when I'm naturally looking at them. That's number one. Number two is I would see whether the tone increases with voluntary effort, or is it a velocity dependent, or it is not a velocity dependent. These are some of the easy, practical ideas that you can use it in your examination to differentiate between spasticity and dystonia, because that is very important. Because treatment would also change based on what kind of problems, what kind of tonal variations that you're seeing in your children with cerebral palsy, right? And then the most important thing you also need to know is what triggers dystonia. This is very important. What are the triggering factors that is increasing this variable tone? What changes this tone? What increases this tone is something. What triggers this increase in tone? That is something which we all need to understand and identify. Why do we do that? Is basically because these triggers are very important for us to take into consideration when we are treating children with dystonia and cerebral palsy, right? Now, I wanted these triggers to be minimized when I'm working with the child, so that the child will be able to focus on posture and function that is at hand, or the task that is happening in my interview, right? And how do we get to know dystonia diagnosis? Now, if I'm not understanding whether how to differentiate between spasticity and dystonia, it is always, you can go back to the documentation that you can read from the pediatric neurologist. You look at this documentation so that you would be able to easily understand whether the child has dystonia. Right now, we all can ask the question that why as a physiotherapist I need to make this differentiation. Yes, it is important for a physio, a practitioner or a therapist to know whether you are handling a child with a mixed tone or a spasticity, or when I say mixed tone, I'm not putting spasticity and dystonia together. Can I see spasticity and dystonia in the same child? Yes, of course, yes. That we have established before when we saw Rice et al.'s study, right? So it can be a mixed tone, it can be a spasticity or a dystonia. Do I need to know whether the child, as a physiotherapist, that this child has a dystonia or spasticity? Of course, yes, because this is going to do a lot of work when you are intervening or helping this child to learn functional skills, right? So in dystonia diagnosis, always remember the overflow of muscles. Always remember about the dystonic triggers. Now, what are these dystonic triggers? What does that what are the things that can increase or increase dystonia in children? Some of these examples are pain. It could be a poor sleep, or it could be a mood that is an excitement. There is a stress, there is an anxiety. All this can trigger dystonia. Constipation can trigger dystonia. Reflexes, general health can. All this can have can act as a dystonic triggers. Right now, that is why it is very important to see the child as an whole rather than just only looking at the motor component of it. Yes, no, you cannot just only look at the motor component and say that no, okay, I would work this way and the other way. No, not possible. You have to look at the child as a whole and then think about how are we managing this child. Now, even a simple lack of sleep child coming into your clinic would that particular day would exhibit more of a dystonic pattern than the other days. So it's very important for us to understand. Sometimes children coming into the therapies are excited about something, then they would severely exhibit a dystonic pattern. So as a therapist, we need to know how do we work on these emotions, how do we try to help them to control these emotions so that they would be able to participate in a function or a task. Right? So keep all this in mind. These are the questions that you need to be asking in your assessment. Look at is there a pain they are struggling with? Is there a lack of sleep they are struggling with? Is there a mood fluctuation? There is a lot of emotions that is running around that is causing dystonia. All this needs to be evaluated during an assessment, right? Now, okay, I will solve running. Now, let's look at the first child, okay? And what you need to do is you need to look at the child's left hand when the child was reaching for the right hand, right? Now, remember the dystonia definition that we have learned. What did we learn? It comes with a voluntary effort. When there is a voluntary effort, when a child attempts at voluntary effort, you see an increased tone in different part of the body, right? It is not only twisting. I've not basically put shoulder twisting, arching and all that in those videos. Why does this? Because I also wanted PTs to recognize that it can be in a very subtle way that no, you should start understanding, picking it up in your clinical practice and then appropriately implement, right? Now, this first child, keep looking at the left hand when the child is attempting to make a reach with the right hand. So if you see it, the moment the child is holding the toy, then you see that no, there is a marked increase in tone on the left hand. This child is a left hemi, right? And you see a marked increase in tone. You would see that the tone keeps increasing. It becomes stiffer and stiffer as the child is manipulating object with the right hand, right? And you would also see, if you can notice a child's foot, you would see there is a marked flexor tone in the foot, in the near the toes, that you would be able to see it. Watch it again so that you would pick this up. And when the child drops it and then suddenly the tone goes off. Look at the thumb. You see that it goes off, right? So that's again, I would put it so that you can see it. The tone increases. See, and you see that it increases. You see the thumb as the child is manipulating it, and now you see that it has become free. So this is a dystonic component, right? Okay, so that's one thing. And then we'll go to the next video. I'll start it from the beginning. She's trying to kick a ball with the left hand and see what happens to her left hand. She's kicking a ball with the left leg and see what is happening to her right leg. Right hand. She's kicking with the left leg. Look at the left hand. The therapist is holding the right hand. Left leg, left hand. She's kicking with the left leg and look at the left hand. What is happening to the left hand? If you see, you would see fanning of fingers. There is overflow of muscle activation in the left hand. Do you see that? So that is a dystonic component. That's a dystonic component. She's again a left hemi. And then you see a dystonic component here. Okay, so I'll stop this and then we'll go into this particular picture. This is going to be very interesting because this particular video, I'll keep showing it again and again for us to understand how we kind of trying to intervene, right? Some of the examples. Okay, now look at him. He's trying to reach for a car and then see what is happening with this right leg, right? I will put it, see what is happening with this right leg when he's reaching for a car. If you see that the lower leg goes into an adduction and then he's trying to lift that leg, right? If you see, it plays again and you see that no, he is lifting that right leg and then subtly the lower leg goes into an adduction. That is again an overflow of the muscle in a very subtle way. It's causing an overflow of the muscle that is compromising with his sitting ability, right? But he comes straight. If you see it, he uses a compensatory strategy to stabilize himself straight after taking the toy. You see that at this particular point, let me freeze it. Now he has come a bit straight. Now, how did he come straight? Is basically because he used a compensatory strategy. What is the compensatory strategy? You see that no, he has excessively flexed his, not excessively, he has flexed his knee a bit, try to hold it with hamstrings, provide a bit of a stability for him to sit straight. So is that a good compensatory strategy? None of the compensatory strategies are good. Is it good for him? Probably it may not be good for him because if he is going to use his hamstrings for a pretty long time, probably he may develop an hamstring contracture. So that is something which we have to keep in mind when we are observing these children. So the first child, there is a lot of fisting. The second child, you see a lot of a fanning of fingers as an overflow. The third child you see is there is a lot of variable tone when he was attempting to pick up a toy with his right hand. You see a lot of a movement that's happening, overflow of muscle activation in his right leg. So these are basically what you call it as a dystonia and then overflow of muscle. So remember the definition and start looking at your children that way, right? We'll go to the next slide. And this is, okay, so we have seen what is dystonia, how are we kind of picking it up in the clinic. And then there is an American Academy of Cerebral Palsy and Development Medicine. They have given a beautiful pathway for dystonia and cerebral palsy and what is the kind of a treatment. Let me focus on the medical management of it and then we would go into the physiotherapy management. If you look at the oral medical interventions, these are the general medical interventions that are available, which are generally prescribed for children with dystonia and cerebral palsy. Now, why I am putting this for a audience who is predominantly therapist is basically many times when I see children, older children coming into my clinic, when I see such a patterns, and then I ask families, do your child taking any kind of oral medications? Then the family would always say that, no, we are not taking any oral medications. Nobody has told us. We stopped going to a pediatric neurologist. Now, this is very important. I would always suggest families and the therapist alike is if you have a child with cerebral palsy and he is spastic or dystonic or there is a mixed tone, it is important for this child to have regular consultation with the pediatric neurologist. You cannot get away with it. Okay, now if I see the previous children, I want these children to be regularly visiting the pediatric neurologist and there is some kind of medication that's been given. Now, if you look at this care pathway and you would see specific indications is if a child has a painful dystonia, there is a certain kind of medication for a painful dystonia that is prescribed. There is a severe dystonia, there is a certain kind of medication that is given. If there is a child with a disturbed sleep and dystonia, there is a certain kind of medication is prescribed. These are very important. If a child is dystonic and then it is interfering with the child's sleep, every time when the child is changing a position and the child becomes stiff and then it is disturbing the child's sleep, it is important to meet a pediatric neurologist, trying to understand this problem, and then probably a kind of oral medication is prescribed to help these children. Please understand this. This is very important. That is why I put this slide. It's very important to seek help whenever no child is exhibiting dystonia and other things that are associated with other problems that are associated with dystonia, right? So these are the oral medications, the summary of evidence that is available for using oral medications. As in the beginning, when I told that many of the interventions that are related to dystonia and cerebral palsy have a very little evidence, or there is a lack of an evidence for it. But these are the best medical intervention that is available for children with dystonia, right? And then what about, let's forget about the medical intervention having an evidence. What about rehabilitation strategies? Do we have any evidence for you using rehabilitation strategies in children with dystonia, dystonic cerebral palsy? I would say there is absolutely very little or no evidence for what we are doing. And even I have kind of established it when we started this presentation, right? So there is some amount of an evidence for a cognitive approach. If some of you would have heard about co-op. Co-op is a lovely approach, a cognitive-based approach, and there is a little evidence for co-op being used for children with dystonia and dystonic cerebral palsy. But the only problem with some of these evidences are, if you look at these literature about co-op used in treatment of dystonic cerebral palsy, you would always see that there are certain criteria that is involved in using co-op. One is most of these co-op based studies have been, only few of the studies are there, and some of these studies have used older children. That's number one. And number two is they have used children with a very good gross motor functional classification system, that is level 1 and level 2. So what about children at level 3, level 4 and level 5? We are not sure, because many times we would see a lot of these dystonic children coming to our clinic at level 3, level 4 and level 5, not level 1 and level 2. So still it is a questionable. Co-op has some evidences for high functioning dystonics, but we do not have much of an evidence for children with very severe dystonic cerebral palsy. That is something which we need to understand when we look at these kinds of research. And second thing is, co-op also requires, the co-op is a cognitive based strategy, so it is important that we also need to have a children who can understand and follow instructions, or who can self problem solve in achieving a functional task. So that is also very important when you are trying to think about using co-op as an intervention strategy to use in children with dystonia. So what are some of the features that as a physiotherapist I need to know about dystonia? Is number one is all these children would have a lot of postural instability. They cannot keep the center of mass within the base of support. They have a very fluctuating center of mass within the base of support that would prevent them to either achieve a functional sitting or functional standing. And moreover, because they have a very fluctuating center of mass within the base of support, adding to it is the increase in tone in extremities triggered by violational effort. If you look at that particular child who was sitting and then trying to take a toy from the hand, you would have seen it like his center of mass is not within the base of support. That's number one. And number two is, because there is too much of an activity that is involuntary activity that is happening in his legs, that is not helping him to achieve a very good postural stability, right? So that is something which we have to look at in our children. Musculoskeletal issues are not common in children with dystonia, but it can arise from the use of compensatory strategies. For example, I have shown a particular child. He was using a compensatory strategy of trying to sit erect using a lot of effort from the hamstrings. If he's going to overuse his hamstrings for a longer period of time, probably in over the years, he may develop hamstring contractions. So that is something. Musculoskeletal issues per se is not common in children with dystonia, but it can happen if they are using a compensatory strategy. So you have to be, as a therapist, you need to predict. So if I'm looking at that particular child, I would say, okay, I don't want this child to develop hamstring contracture in future. So you predict what is going to happen by looking at their movement strategies that they are currently using, right? So what is the commonest sensory related issue that you would see in children with dystonic is it's always a visual motor control. They would have lots of challenges in looking at an object and reaching an object, and then no processing it visually when they are not doing a task. That is something something amiss in children with dystonia. So they would have a problem in visual motor coordination. So we'll go back to that video again of the boy who is taking holding a car toy. You would see that how he's processing his vision. That's something which you have to also record it when you're looking at a child, right? Some of the children with dystonia will also have excessive startles for sounds. Now, they may not have only for sounds, but they will also have a visual for visual movement. They're sitting and somebody walks in front of them, they would get a startle. Or if there is their own internal thoughts can also startle them. They are sitting and suddenly they will get startled without any external provocation, right? There is an internal provocation, internal thoughts, fear, anxiety can also startle them. I have seen a lot of children who have startles which would destabilize their posture, and then they would not be able to maintain sitting, right? Or other functions. Okay, so we would go back. Look, I would pause this video for a moment. Look at his legs. He's trying to hold a ball, the same boy, but look at how much of an involuntary movement, that's overflow of muscle action that is happening in his legs. Do you see that? What this is doing is this is basically pushing his center of mass posterior to his base of support. So no way he is going to definitely kind of have a very stable sitting unless and until we kind of provide that stable sitting for him. So this is going to be a problem for him. So this would not help him to functionally achieve a better sitting and then do things that he is supposed to do in sitting, right? What we are expected to do in sitting, to play with toys, do puzzles, or eat a finger food, or eat a meal, or coloring, writing, drawing, whatever it is. So with this kind of a posture, it's always going to destabilize the center of mass beyond the base of support, and then would not help him to achieve a good postural stability in sitting, right? We'd go back. That is, so if you look at it, I cannot show you the vision because it's all blinded. But if you actually see it in your children, then you would see a lot of visual motor coordination difficulties. You see that the leg is just turning inside and then going up when he is attempting to pick up a toy. And then when he's sitting straight, you see the knees. The knees are just going into flexion. He's stabilizing his leg towards the table where he's sitting. That's basically excessive use of hamstrings to get a bit of a stability in his posture. That is over a period of time may not be good for him because he may develop an hamstring contraction. Okay, so what are the general principles of working with a child with dystonia? Is first one is, in management of dystonia, the trigger needs to be addressed first. We talked about lots of triggers. We talked about pain as a trigger, sleep as a trigger, emotion as a trigger. All this needs to be addressed in a session, right? So if you're not addressing triggers, you will not be able to help a child to achieve function or functional independence. Why does it? Because without triggers, you cannot treat the overflow of muscles, involuntary action, increase in tone, this variable tone that you would not be able to treat without addressing those triggers. Okay, so now what are the triggers? Now, some of the triggers that can happen during a session is basically what I would usually tell therapists is do not go into complex movement patterns. Now, say for an example, if a child is a very severe dystonic, what is the point in taking them into a prone lying and working on prone transitions? Because this prone lying and prone transitions are basically would be very challenging for them. If it is very challenging for them, it's going to trigger their emotions. If it's going to trigger their emotions, they're going to be too much dystonic. If they're going to be too much dystonic, they're not going to learn anything. If they are not going to learn anything, there is no point even taking them and teaching them all these transitions. You remember this? So in the therapy, what I would always suggest is try to work on positions, try to simplify postures for them, simplify movements for them, and help them to learn function. That's it. Now, I don't need to go into developmental sequence. I don't need to go into developmental patterns to train function for them, build strength, build control, or improve selective control for them. What I all needed is I wanted to see them functioning that are related to their daily life, right? So I don't need to really work on postures that are going to be extremely challenging for them. That is something all therapists need to understand and then apply in a treatment setting. So I would not go into a very challenging, complex movement patterns for children with dystonia. What I would do is I would use simple postures, the postures that are meaningful for their life, the positions that are important for their life, the positions that are improving their participation in their daily activities, or positions that would help them to learn to be functionally independent. So those are the things that I would be using. And look at these triggers. I need to control these triggers when I'm treating a child with dystonia. Second thing is, so the first one is you take care of the triggers. The second one is what you need to do is you need to be very specific, goal specific. You cannot say that, no, I'm going to build strength in her spine, in her or his spine. I'm going to build strength in his hamstrings. I'm going to build strength in his quadriceps. I'm going to build selective motor control. All these are not specific goals. Specific goals are basically you design goals that are meaningful for them that would help them to participate in their day-to-day activities. Those are the goals that you would be looking at. Now, that is very important. If you look at any cerebral palsy research that has come in the recent years, one of the most important thing that is always recommended is try to be task specific or goal specific. Have a goal and be specific about it. I remember one of the study that is talking about deciding goals when you're working with children, right? If you're working with a child without a goal, and for them without a specific goal, and then they wanted to learn a particular function or a movement, it would take at least 40 hours of training. But if you are goal specific, it only takes 20 to 25 hours of training, right? Now, that is what a goal specific, having a goal and working towards a goal will do for you. If you have a goal for your child and then you're working towards the goal, it takes a very short span of time for you to achieve a goal, rather than trying to work aimlessly without any goal and then just working on movement patterns. So that's something which we all need to understand, right? The most important thing is when you're working with child with dystonia is focus on postural control. Focus on the trunk control, building a very good trunk control for them. For you to build a very good trunk control, what you need to achieve is distal stability for them, right? If you look at that boy who was trying to catch a car, what is happening with him is, what is destabilizing his posture is, he does not have a very good distal stability in his legs. He's not able to keep his legs down. If he can keep his legs down, probably that is the starting point for him to build a very good postural control, right? In his case, he does not have a very good distal stability. He does not have a very good control in his legs to keep his legs down and then work on his posture. That is not a luxury for him. So it is important that we try to help him to achieve that distal stability so that he starts working on his postural control. If he improves on postural control, he's going to sit better. He's going to do a lot of function and participate in a lot of sit-based activities better, right? That is one important thing. Second important thing when you're working with dystonic is simplify motor learning by limiting the degrees of freedom. Now imagine this is something which a physiotherapist need to be aware of, right? Now say for an example, if I'm working on a child and the child is sitting, right? Like that boy, right? When you look at that boy, when he was sitting, there are a lot of things he has to control. He has to keep the center of mass. He has to sit straight. He has to also keep his legs down. He has to keep his relaxed. There is a lot of things he has to do. If I in a session, if I keep telling him, look, you have to keep your legs down. Look, you have to sit straight. Look, you have to keep your center. You have to come forward a little bit. Look, you have to keep your hands together. That is too much of learning. Too much of learning. I have to learn to control different parts of a body at the same time. That is not going to happen if you're working with children with cerebral palsy. What you need to do with children with cerebral palsy is simplify their motor learning. How do you simplify motor learning? Try to restrict what they are supposed to learn. Try to control what they are supposed to learn. That is the most easiest way you can approach a child with cerebral palsy, right? So on that note, distal stability is something which is very important. I would show you distal stability here. Look at these pictures. Now, if you see a child here standing, what I've done is I've given a very good distal stability for them. Imagine that their hands are, there's a lot of involuntary movements that is happening in their hands. The best way to control those involuntary movements is trying to provide a stability for their hands. When you provide stability for their hands by holding something, holding a pole or holding a horizontal bar or something in the front, basically fixes the distal part of their extremity. When they fix the distal part of the extremity, basically what happens is you are trying to minimize those involuntary movements that are happening because of dystonia. That's number one. And number two is it also gives them an ability to work on their posture, work on their trunk control. So that is something. So here is a boy who is standing. I've given some kind of a stability for his legs and some kind of a stability for his hands. That is basically that would help him to build some control in his trunk. So this is one picture. This is the boy who is sitting. Again, I'm working on his distal stability, give him some distal stability to his upper extremity by helping him to hold on a pole so that he was able to manage his sitting and try to work on his sitting by building control on his on his trunk, right? Now imagine, think about it, using this particular principle and translating into a functional activity. Suppose if I'm having a child where child is holding on to the pole with one hand and then working on the postural control of the trunk, but at the same time also using the other hand to play with the toy, or using a finger food for eating, or trying to learn to flip pages, or using manipulating a particular toy would be of a function. So that is how we should start thinking of helping children with dystonia when you're working on improving their function. So that is some of the examples of distal stability, right? Now look at the distal stability that we have used for this particular child. Look at his posture that was going up and down for him, but here you see that his posture is relatively stable here. Now how we have given a stable posture for him is, you see that we have added some little bit of weights for him. There is a little bit of a strapping to help him to stabilize his legs on the floor. That's number one. And then we have used a wedge for him to get the center of mass a little forward. And then that gives him a little more stability than being in this position, right? So that is an example of using distal stability as an intervention tool to help children to develop a very good postural control in sitting and standing. Why am I emphasizing sitting and standing? Is basically because these are the postures that are very important for them in their daily life, which are very important and meaningful for them, right? Okay, so the next kind of a set of a strategy that we would be using for children with dystonia is embracing cognitive strategies. So I talked about co-op. Co-op uses these kind of strategies. There is one particular paper which I have not mentioned here, is by Hortensia Gimino. She is a UK-based occupational therapist. She has come up with an article called as Harnessing Cognitive-Based Approach in Children with Dyskinesia. Right? I don't completely remember the paper. That is the kind of a paper it is. That's the title. If you put the author's name and then talking about harnessing cognitive approach in children with dyskinesia. You would get that paper. That particular paper talks about these kinds of different cognitive strategies. Now, these are some of the cognitive strategies that are very important for children. One is a distraction. Distraction can be a method that can be used to minimize involuntary movement. Now, I don't know whether you have observed it. Many times I have seen children, if you put a small, gentle music for them during a therapy session, probably they would be able to focus better. Why this is? Because the music acts as a distraction for them to help them to focus on a task, right? So that is one thing. Some children watching nursery rhymes or YouTube videos, they would be able to perform better. So these are passive, these are called as passive distraction. What is an active distraction? Active distraction is basically they are trying to talk through while performing a task. So what basically it does is, if you understand what is causing involuntary movements in dystonia, is basically a cognitive intent. Oh, I have to move now. When they think about this cognitive intent, when they are focusing on this cognitive intent, what happens is this causes an overflow of muscles in a different part of our body. So by asking a child to listen to a music or looking at a video or trying to, if they have a speech ability and then you are asking questions and then they are going through, what happens is it takes away this cognitive demand that they are putting on to a voluntary effort. When that cognitive demand is taken off from the voluntary effort and trying to create a cognitive load elsewhere, what would happen is basically that can minimize their voluntary effort. So that is one thing. So one is distraction. Distraction can be used as a method in minimizing those involuntary movements or overflow of muscle action. That's number one. Number two is you also have an emotional regulation, right? Emotional regulation is trying to help them to focus on things that are non-anxious and non-stressful. So when they come into a treatment session, they should not be worried about, okay, my therapist is going to put me on challenging postures. No, the therapy should be very pleasurable. So when they are coming into the sessions, their emotions are in a very pleasant level, so that they are able to focus on tasks, and then they believe that those tasks are something that does that would lead to stress and anxiety, right? So that is trying to help them to have a streamlined regulation of emotions is very important when they come into your treatment session. That is number two. Number three is motor imagery. Motor imagery is thinking about the activity task that is hand. I'm thinking, I'm mentally rehearsing myself, how I'm going to do an activity. This is something which is not going to be easy for children who are having a cognitive difficulty or they have an intellectual difficulty. They cannot think through this. But if a child can cognitively think through it, can imagine their steps, or if you can ask the child about the steps, what are you going to do? Now, say for an example, if you want the child to fix a puzzle, you can ask them, how are we going to fix the puzzle? The child is explaining you the steps, or you can guide the child in explaining the steps, and then the child first narrates the steps that are involved for fixing the puzzle, and then actually going into the fixing the puzzle. That is motor imagery and mental self-guidance. This would definitely work if a child is cognitively good, and then they can actually verbally say you that, what are the steps that are involved for accomplishing a particular task. They can verbalize it first and then go into the action, right? And then there are externally focused attention and then an internally focused attention. The externally focused attention is the attention is devoted to an object or a task or a location. Now, say that is externally focused attention. Now, I would be asking a child to look at a particular space where the child has to put this particular toy. Then it is a externally focused attention. The entire attention is redirected from movement towards an object that is in space. That is externally focused attention. Now, what is an internally focused attention? Internally focused attention is focusing on a body part. Look, how are you moving your hand? Try to hold it, right? Try to hold it in a way that you can keep it there. So you are directing the child towards a body part that is involved in the task, that is internally focused attention. So these are some of the cognitive strategies that you can use. Some of these cognitive strategies are basic. As it is a cognitive strategy, basically it requires a little bit of ability of the child to understand what you're asking them to do. If a child has a cognitive ability, many of the dystonics will have a very good cognitive ability when compared to the child with spastic quadriplegia. So using that cognition that the child has would be of a greater advantage when you're working with children in a treatment session. And the other thing that you would be using is a lot of a supportive weights. Right now, I would be using standing frames. Standing frames are a better way of teaching motor control. Why it is because if you remember in one of the slides I was mentioning is how a motor learning can happen faster in cerebral palsy is minimizing the degrees of freedom that the child has to control, minimizing the number of parts in the body that child has to control. If I put a child in a standing frame, imagine, and then I've supported them till the axilla. Now, one of the things that child can focus is working on building the neck control rather than worrying about the entire part of a body that how am I keeping my hands, how am I keeping my legs, how am I keeping my body, right? So trying to minimize it. Standing frame is one of the best ways of working on a selective spinal control or if you're specifically working on the neck control. Children should have a very good seating, adaptive, very good chair, very good table in the front for them to basically sit and then because one of the important things that is important when you're working with children with cerebral palsy is you're trying to maintain a very good alignment for them so that they're not using bad compensative strategies that would lead into contractures. So good seating is very important. That's number 2. Number 3 is you can use body suits, compressive garments that can basically help them to give them that sensory feedback to their body of where they are in space. That would help them to minimize involuntary movements that you see in dystonia. Apart from that, you also need to have an adaptive equipment because we are dealing with children with GMFCS 4 and 5. They may require a wheelchair or walkers. If you're using walkers, my preferred walker is an anterior walker. I never recommend a posterior walker for children because of the center of mass that it displaces in relation to the base of support. I would always give a thumbs up for the anterior walkers, but anterior walkers are not something that is available in the market. When you go to the market, you will always find posterior walkers, but anterior walkers are basically used so that I recommend anterior walkers basically because it helps the center of mass within the base of support, helps the child to be well aligned when they are standing and then pushing the walker and initiate walking. So in a nutshell, what are the important things that you need to remember is one is you have to manage triggers. That's number 1. Number 2 is come up with goals that are very meaningful for the child. Do not use postures, positions that are irrelevant for the child, not meaningful for the child. Those postures are probably can trigger dystonia. So don't use those postures. Use postures that are meaningful for them. Number 3 is close chain activities. If you remember distal stability is the other name for distal stability is close chain work. Close chain work I have seen is a beautiful way of building postural control and function if you embrace it and use it very well. That is number 3. And number 4 is use cognitive strategies whenever you see a child who can cognitively understand and process information very well. Right? I thank Shivani. Shivani is a director in our center, and then she kind of given me a good suggestions of how to build this presentation. And a lot of videos that you have seen in this presentation is basically her clients. So a big shout out to her for providing me this client videos to show for today's presentation, right? Thank you for your patient listening. I will stop share. If there is any questions, we can go through it.
So anybody wants to ask questions, you can raise hand or unmute and ask. So in the meantime, Hansika, do you want to present the questions that was presented online?
Yes, ma'am. So, sir, we had a question by Miss Fariha. Her question to you is: does weight training help in dystonia management? If so, what is the suitable weight to be used?
I think I have covered that. Know what? Basically, if you are looking at an evidence-based practice, we do not have much of evidence working with what works and what does not work in children with dystonia. But there are general guidelines that you can um, try to use when you're working with children with dystonia, especially in cerebral palsy with dystonia, right? So those things I have actually covered, I guess. This is probably a question that I was asked before the start of the program. I assume that it is before the start of the program. So I think I've hopefully covered it, know what works and know how we need to work. Um, one thing about working with children with cerebral palsy is, no, you're not going to create magic. Okay, you're not going to get them out of. You're not going to get them to be normal. That is not what we are now working at. What our treatment intervention are basically aimed at helping them to be functionally relevant, functionally independent as much as possible. Right. That is what now we are trying to that is what we are trying to do with children with any type of cerebral palsy. So the question of whether it would work is it's going to be depending upon the child's severity and what kind of treatment strategies that you're coming up with in trying to improve function. Now, if I'm going to use an intervention method that is only um, focused on only movement strategies, trying to know only work on movements. No, probably I may not even improve any function. So that is why I said no, it has to be goal specific. You have to keep the function always in the mind and see, what are you trying to improve for this child? How does that improvement that you're bringing in an intervention that is going to help the child in day-to-day functions? That is how you should start thinking. When you start thinking in that way, you see a lot of a difference. You see a lot of changes that you can make in these children.
Lalita C, you can unmute and ask.
Thank you. Thanks for the session. Actually, I cerebral palsy kid, and as for the points that you have shared earlier, do you have any in? She is undergoing physiotherapy and occupational therapy from specialists. But as a parent, what would you advise us at home? What is it that we could do to help her add to what is being done at the sessions? Because the sessions are 45 minutes, and we as a parent would not be able to do what is being done at the sessions effectively. So any tips or inputs that would really help us make it better for them?
Okay, so one of the things, this is a very common question that many people ask me, right? And then I also keep telling the families and then the therapist alike. Now, if what I tell to the families is, if you're going to heavily rely on a 45-minute session that you take every single day, that your child is taking it from an intervention center, if you're going to rely on that 45 minutes is to create that change in your child's life, I don't think so. That is the way that families should look at it. I would always say to the families is your responsibility of taking care of your child does not end when you enroll a child into an intervention center. Your responsibility of taking care of your child starts after you enroll a child in an intervention center. That's the most important thing, right? So my question is, okay, now what is that the family should be doing at home, right? Do they exactly follow what is the therapist is doing in the clinic? I would say that is not how home programs are designed, right? Now, I would not make a parent become a therapist. Okay, that would be a very good thing to do, but that is not how it's going to be. Now, why do I say that is basically because how much ever I can know do a plumbing, I would never be a better plumber than an actual professional plumber who is not doing that day in and day out. Correct. So what is that family should be doing? Now, I would say the minimum thing that family should be doing is basically number one, do they have adaptive equipments in the house that facilitates a very good aligned sitting, that promotes functional activities in sitting? That means now a child can sit, and can I promote self-feeding in that sitting, engaging with toys in that sitting, or can I do, how do I get my child to do that? That's the most important thing, I would say. Second one is, if I have a child with cerebral palsy who has not learned to stand and walk, I would say having a standing frame is absolutely mandatory. Why I say that is, there are a lot of good things would happen if you're using a standing frame. You're using a standing frame and the child is standing for almost somewhere between 30 minutes to 120 minutes. There is a lot of a benefit in learning, right? Now, since you are a parent, I would want you to go back to your therapist and then talk about this. One of the things that we use for standing frame is there is a test called as SATCO. The therapist would know it. What is SATCO? SATCO is a segmental assessment of trunk control, right? You are segment wise analyzing the trunk control and say where the child is not able to manage trunk control, where the child is having a difficulty in managing the trunk control. Now, it is not only related to the abilities of the child. Even a child who is walking may have challenges or a poor trunk control, right? So doing a SATCO assessment and then developing a treatment intervention into a standing frame, and then that standing frame is used at home, would bring a lot of a difference in children, right? So what I would think about it is how the child is sitting when they are feeding, how the child is sitting when you're giving them bath, how the child is sitting when the child is watching a TV, how the child is sitting when the child is playing with toys, how the child is sitting when the child is using probably participating in an academic session. That itself is a form of an exercise that builds a lot of control in their spine if you are mindfully working on it. If you are, that is why I would say, no, these are the things that if a therapist can empower the families to take home and then try to use it, you would see a lot of a difference.
Thank you, sir. If you could share some adaptive equipment for sitting that you have showcased earlier,
Okay.
that would really be very helpful. Few examples that will help us. Thank you.
No, what you can do is probably you can get in touch with me. Okay, I'll put my email ID here, so you can get in touch with me. I would now share you some of the things that I use, and then we have not developed it ourselves. I would share it with you. Probably you can use it. Look at it and then use it.
Thank you so much, sir.
So maybe Shika can ask next.
Yeah. Hi, Dr. Sundar.
Yeah,
So
hi, Shika.
I just wanted to know, like in the first three videos which you have shown, in the third child, the one, who had a lot of movements, it was clear that he had dystonic kind of movements.
Okay.
But in the first two children, isn't it, the overflow of the muscles is only because the task was difficult? Like it would happen in a normal person also. Like suppose I try to push a heavy box, I would, try to close my eyes also, clench my teeth also. So isn't that kind of a normal overflow of the muscle rather than being dystonia? I mean, I couldn't really distinguish between.
Okay. Now, okay.
Yeah.
The first child is basically holding a toy. Okay, it was basically a stacking cup. Okay, the child was holding a
Right.
stacking cup with a normal hand. Okay, now
Right.
what you see is now when the child holds the cup with the normal hand, and you see that no, this
Huh.
suddenly start fisting. And as the child starts manipulating it, you see that the fisting gets more. You would see in the form of how the child is pushing the thumb on the thumb and then trying to squeeze that hand. Now that is a dystonic posturing, right? Now what happens is when I'm doing a voluntary effort, now by the definition, if you look at it, I'm doing a voluntary effort, but that voluntary effort causing a problem elsewhere in a different part of the world. Okay, now I just wanted to show it, that's why I showed it. But imagine for a moment, imagine this child has to hold a ball or trying to hold a water bottle and open or trying to hold a stacking cup and then remove a smaller stacking cup from that cup.
Okay.
Would this fisting would really affect the function? Do you think it would really affect the function?
Yes, yeah.
Yes. Why it is because
Yeah.
that increased overflow would not allow the child to hold the cup, isn't it?
Right.
Correct,
Okay.
right? So that is that particular child. Second child is only kicking a ball. Okay, she is probably around, I think, 3 years. Now, kicking a ball should not cause fanning of fingers. Now, fanning of fingers is very classical in a dystonia. Okay, she is not showing anything that you and me would do. Okay, now when you kick a ball, probably imagine you're kicking a medicine ball, which is very heavy. Okay, I'm sure probably you will hold your breath. Okay, simple strategies are you hold your breath, you clench your teeth. That's it.
Right.
You cannot show fanning of fingers because now you're doing it, correct?
Okay, got
Did you
it.
get it? So now,
okay, yeah. So, got it. Yes.
These are some examples, but there are many dystonic patterns that you can really see. What I'm trying to tell is basically look at these examples. Don't stick to these examples, but start understanding the overflow very well.
Yes.
Yeah.
So basically, these are not the normal overflow of the muscles that we would see in a typical child or people, right?
Correct.
Yeah.
Exactly. But the normal overflow is basically come with the complexity of an activity. But whatever the activity that you are seeing, the video is not very complex.
Right. Yeah. I got it. Thank you so much.
Next question, couple of questions. Let's take it from YouTube. So Kruti is asking, will collar help in dystonia when we want to work on trunk and sitting?
Collars will definitely work. Why it is basically because now this is now whenever I work on children with lack of neck control, that is possible in children with dystonia and other types of cerebral palsy. Um, um, when they do not have neck control, fundamentally what I would do is I would use a collar and then work on upright postures for them to build neck control, right? I generally do not, I use other postures, but basically my go-to posture for working on building neck control is using a collar. Why using a collar? Because with a collar, I would be able to get their neck into an alignment. Okay. Now, what is the fundamental alignment that we are looking at, building a neck control is basically an upright head posture with chin tuck. If you're using an upright head posture with a chin tuck is basically a very good aligned neck that would help them to build control over the neck muscles. Now, why do I talk about an alignment? Is basically many of you who are physiotherapists would understand it, would have studied in biomechanics that length tension relationship, right? Now, the tension of the muscle is related to the length of the muscle. So, first thing is for me is I would go and align, provide an appropriate length for those muscles so that the muscle can start building, generate strength or no force or no build tension so that they build a bit of a control in the neck. That's the most important thing. Do I use prone positions, supine positions? Oh, I would selectively use it based on what the child is not able to do. But generally my go-to position is using a collar basically if the child does not have neck control.
Okay, another one from YouTube. Konika is asking, vestibular input, will it help in truncal control using ball exercises? Can vestibular input help in control using ball exercises?
If definitely have no. There are many challenges to that question. Number one is I have to presume that all dystonics will have problems in vestibular processing. That may be true or may not be true. We should find a way, or we should first understand from a point that this particular child has a vestibular processing difficulty. If the child has a vestibular processing difficulty, then I would assume, okay, what kind of vestibular based interventions that would help. Now, putting a child on a ball alone is not the only way to help them child learn vestibular processing. There are other equipments that you can use to help child, other safest equipments that you can use to help child learn vestibular processing. But putting a child on a ball may be a right thing or a wrong thing. It depends upon the child. Some children with dystonia will start exhibiting more tone when you put them on a very unstable surface. So if a child exhibits more tone when you put them on an unstable surface, I would say that no, I would not be doing that. That is number one. But if you can safely take the child on the ball without helping them to exhibit dystonia, but also try to work on vestibular system, I think you can do it. But not starting from a point that assuming that all children with dystonia will have vestibular processing difficulty. That has to be first established in a first place. And it is not easy to establish sensory processing difficulties in children who already have motor difficulties.
Okay. So, Lavanya, do you want to ask your question now?
Yes, ma'am. Thank you, sir, for this informative session. And I'm working with a dystonic child. My version is the child will be using more of the right hand. Just now she started picking up the objects and all, but the left will be very minimal movement. So what I'm doing is just applying the CIMT, just resisting the right hand, resisting in the sense with a finger resistance, so that let her use the left. I'm getting a little bit positive results. She is trying to use the left. Is it okay to use CIMT for this child?
Okay, so I would look at it from an evidence-based perspective of how to use a CIMT, and then also what is the practical ways of using CIMT. Okay, that those two perspectives I would give you and see what would work for you. Number one is from an evidence-based perspective, when should I use a CIMT? If a child lacks spontaneous hand movement. Okay, when I say spontaneous hand movement, can lift a hand, move towards an object. It could be an accidental swipe or accidental just touch, or for a sensory feel. All these are considered as spontaneous hand movement without even actually holding an object or manipulating an object. That is a spontaneous hand movement. If you look at the literature suggests that when a child does not have a spontaneous hand movement, you start with CIMT. When a child achieves a spontaneous hand movement, you should be shifting from CIMT to a bimanual practice, right? You don't stuck with unimanual practice, bimanual practice, because the outcome of any upper extremity based intervention is bimanual performance. My ability to use both the hands together for various day-to-day activities, because I need both the hands for doing various day-to-day activities. Okay, I don't use it with one hand. You and me does not use one hand for various activities. We always use both the hands for various activities. So this is how basically the research suggests us to do. So you start with CIMT when the child does not have a spontaneous hand use. Is a very good approach. Both CIMT and bimanual has a very good evidence to work for children with cerebral palsy. Look at the recent Novak article that was published in 2019. That's the recent one, I guess. It provides ample of evidence that CIMT and bimanual works. But this is the way that CIMT and bimanual works. Having said that, can I continue to use CAMT? Of course, you should be continuing to use CAMT if a child is asymmetrical. Okay, but try to monitor the doses, how long you should be using CAMT. The general recommended suggestion is 2 hours per day for older children. You constrain the normal side for 2 hours and then allow them to use various functional activities, engage them in a unimanual various functional activities for 2 hours a day. Now, 2 hours a day, when I said it's not just going to happen in the clinic, it should happen at home, right? So basically, when I recommend CIMT, I would say the families to do it at home rather than I'm doing it in the clinic.
Yes,
Because
yes.
I would not have that much amount of time to do in the clinic. I would be working on other things, but I would give the family a program. There should be a structured program of what they are doing for 2 hours. Many times what families would do is, no, they would constrain it on the normal side and then leave the child, allow the child to explore. So that's not going to improve faster. What will improve faster is that 2 hours, there is a program that a family is following it. What are the kinds of objects they are going to pick, what size of an object they are picking, what size of object, what shape of an object that they are working, what component of movements that you are working. All that has to be integrated into the objects they hold, reach, manipulate, and release. So that is how the plan is. But I have seen some of the clinicians who does casting of the normal side and leave it for a week or 10 days. So if you cast the normal side and leave it for a week and then allow the child to only use the affected side for the entire week, that would be too much on a child, but I'm not sure whether something that you wanted to explore. It's very complex, it's too much, you are forcing the child too much. It would be too much of a burden on the child doing that, but I've seen people doing it. Okay, and then looking at so those things, you think about it and see what would work for your child, and then try to what would work for your child and your family. Based on that, you can make decisions.
Okay, sir. Sure. Thank you, sir.
So I think we can take one last question from Sanjeev Kumar.
So I think I'm seeing it in the chat box he has put.
Yes.
Cognitive strategies you have mentioned internally focused attention, while it won't increase involuntary movement furthermore. No, it will not. We are not per se. See, what happens is basically cognitive strategies are basically what happens is, see, what is causing this involuntary movement is when a child is trying to take a voluntary effort, the child is also showing an involuntary movement in the other part of the body. So if you look at the mechanism of how this is happening is, when a child cognitively intends a movement, there is an overflow. That's how you relate it. When the child cognitively intends a voluntary movement and then starts executing the voluntary movement, there is an overflow of action in a part elsewhere in the body, right? Now, what we are trying to basically do is, we are trying to reduce that cognitive load on the voluntary action the child is doing and try to help the child to focus on a component of an activity that child is doing, or focusing on something else. So that is how it is. Now, say for an example, rather than the child is thinking about, I have to lift my hand, if I direct the child of how the child has to be holding that object with her hands. Now, how the child has to be looking at that hand and position that hand for a task success, is basically reduces that cognitive intent that the child is putting on the voluntary control, but thinking on the movements of how the child is can be successful at tasks. So that is the difference in an internally focused and internally focused. So internally focused would not generally increase the voluntary movement, because you are not asking the child to think about that voluntary effort and overflow of motion. What you're trying to do is, you're trying to take the child from the focus of the entire voluntary movement and the overflow of motion, and help the child to focus on a part of a body that the child is executing as a part of or helping the child to focus on an object, then it becomes an externally focused. So what you're trying to basically do, if you look at all the 6 strategies that you have seen in cognitive, basically you're trying to help the child to redirect their attention to a different part of the task or to the environment. That is what you're trying to do. So when you do that, basically what you're trying to do is you're trying to reduce that cognitive intent the child is trying to put it on the voluntary effort and then the overflow of action. That's it. Even if there are some of the things that I've not talked about during that video that we have seen in that child is, if you look at that particular child, before even he started initiating reach for that car, basically, he started lifting his legs. So every time, before that intended voluntary movement, you will see a lift of the legs. Why it is because there is a cognitive demand for him. Whenever he thinks about this voluntary effort, then basically, that lifts for him. So if I can redirect him to how is he, trying to hold an object, how he has to open his fingers, how much of reach that he has to do with his hands. If I can redirect him towards that, it removes that cognitive intent and puts it elsewhere. So you're redirecting the attention. So when you're redirecting the attention, basically what you're trying to do is you're trying to minimize the overflow.
Thank you for that, sir. If any other questions, I think there are no other questions. Okay, sir. So I would like to extend my heartfelt gratitude to you, sir, also on behalf of the Brainchild Trust, for taking the time out and giving us this wonderful insights on dystonia and helping us as therapists to guide ourselves through dystonic CP, which, as you mentioned, is a very challenging task for us. And also thankful to the audience present today for making time and joining the session with us today. Hope it was helpful for all your kids. Thank you, sir.
Thank you. It's a pleasure.
So thank you, everybody, and wish you all a happy new year in advance. So we'll close the session, and the recording will be there on YouTube for you to access even later on. Thank you, Dr. Sundar, and thank you.